Good morning, everyone. We are at week 11 of Cardio Echo Weight Management, and I would like to remind you to add your name to the chat box so that we can record your attendance. If there are multiple people in the room with you, please add everyone's names and their roles so that we can record everyone who might be in your room. If you happen to be on the phone, please use *6 to mute and unmute yourself. And there's a phone number here if you happen to get disconnected or if you need help, contact Rick in the meantime. I will go around the room here and we'll all introduce ourselves. I'm the clinic coordinator, Shannon Swikowski.
I'm Jim Warner, weight loss behaviorist.
I'm Gautam Rao. I'm the director of Cardio Echo.
And I'm Rick Cronacci. I'm the web content producer for the cardio program.
Thanks, everyone. Dr. Rao, you're ready to go.
Okay, back. So thanks for joining us this morning. So we have 1 week left after this, so we're coming to the close of this series. I would argue that this is potentially the most important didactic lecture that I can give you, and it's about collaborative care. And there's some compelling reasons for that, which I'll get into in a moment. So these are our disclosures. I don't have anything to disclose, neither does Dr. Werner, but you can read Dr. Brzezinski's, Karukian, and Taylor's disclosures at your leisure. So let's talk about partnerships and collaboration and what it means. And I think this goes back quite a ways, and everybody kind of comes to the same place, including the National Academy of Medicine's Obesity Committee. And I run a pediatric obesity cardiovascular risks echo series for a number of years. And I can tell you that I've encountered the same phenomenon over and over again, is that you have these people that are very, very passionate about caring for children and adolescents with obesity. And they come to me and they say, well, I'm working with this family and I'm really frustrated, and none of my partners in practice is interested, the nurses aren't interested, and the nutritionists don't want to see these kids. And I'm at my wit's end because I'm struggling to do this on my own. And the answer to that, of course, is you're not supposed to do this on your own. The reason that the National Academy of Medicine's committee includes so many different disciplines is not only to promote competencies across the healthcare spectrum, but to encourage collaboration among all of those different groups of people, whether they are nurses, advanced practice providers, physicians, specialists, school nurses, teachers, public health officials, etc. It was never meant to be a single effort. I can tell you that physicians and other providers cannot solve this problem on their own. So let's define a collaborative approach to obesity care. List and describe a minimum of 2 advantages of a collaborative approach. Describe how a healthcare provider might collaborate with an outside professional in collaborative obesity care. There is no right answer to this. And if you look at the National Academy of Medicine competencies, there are suggestions, some of which I advanced to the committee, but really I think we're going to go through an exercise ourselves to see how we can organize our clinical environments around a collaborative approach. So a collaborative approach essentially means that no single individual is responsible for the care of an individual who has obesity, and in terms of promoting weight management. It is a collaboration among at least 2 or more people, and it's usually multidisciplinary. And the rationale is quite clear. Obviously, there's the time factor. To provide effective counseling to a patient, really in the primary care environment, you're looking at about 20 to 30 minutes. Our total appointment times in FIT-or-Me are probably all over about an hour, I would say about an hour. And when I worked in the pediatric center, our total appointments were 2 to 3 hours long because there was a lot of laboratory testing and body composition analysis, and every child got a behavioral counselor and a nutritionist as well. So they were very long. So there's no way that you can provide a significant amount of time on your own. Lack of expertise is a significant issue as well. So physicians and other providers are very good at some things. Nutritionists are good at other things. And behavioralists are better at other things. So there's no single group that has all the expertise necessary to manage this problem. So obviously you could intensify the degree of support. You can also provide more frequent contact for patients engaged in weight management. So If a patient cannot see you as a provider when they return, perhaps they can see a nurse who is also very passionate, or a medical assistant who's very passionate about the issue, can provide some counseling and advice to reinforce it over time. Weight management success is dose dependent, of course. The more contact you have, the more likely you are to succeed. And of course, there's the opportunity to build community among healthcare providers. We'll look at that in a moment. And of course, the issue of effectiveness. Collaborative approaches consistently have been shown to be more effective than a solo approach. So collaborative care models are not new. You may have seen this before. This is the chronic care model, which has been around now, I'd say 25 years that it was first advanced. Obviously the bottom is the most important. To have improved outcomes, there is a collaboration among healthcare systems elements, the community, that leads to active, informed patients and a proactive, prepared practice team. And those resources include self-management support, delivery system design, decision support, clinical information systems. Of course, there's been lots of advances in these areas, but this is the origins of the collaborative model for obesity. This is the patient-centered medical home, which is also consistent with the approach that we're promoting. Multidisciplinary teams in obesity, role of the modern patient-centered medical home, in which the other providers, other professionals within a patient-centered medical home each have a specific role and reinforce the same message over time to address this chronic problem. And this has been shown to be effective as well. Here's an additional review you can look up if you wish. Multidisciplinary team-based obesity treatment in patients with diabetes, current practices in the state of the science. Essentially, there's no question, there's unequivocal evidence that this approach is more effective than a single provider-based approach across the spectrum. And this is, of course, the Lancet review that we've seen. And I just wanted to go through the findings here. This is a systematic review of multidisciplinary approaches. The conclusion is probably something to look at. Systematic reviews of randomized trials conducted in primary care reveal very similar findings. A review of 15 trials, the pooled results indicate a weight loss of 1.36 kilograms at 12 months. So not super effective. However, much more effective than trying to do this on your own, which is not associated with any significant degree of weight loss. So given all of this evidence, the National Academy of Medicine, which our committee is led by William Dietz, Bill Dietz, who was the head of the CDC for a number of years and is now at George Washington, developed something called an integrated framework for the prevention and treatment of obesity and its related chronic diseases. And within the integrated framework, you see a lot of the chronic care model. So there's family and individual empowerment and engagement in the center. But if you look on the left, it's very much clinicians working with their resources, information systems, et cetera, but also community systems as well, which are integrated together to lead to a more robust and effective approach to obesity care. I don't think it's necessary to remember all the elements of this framework, only to know that it has a foundation that's been around for 25, 30 years. So let's look at some general principles when we talk about collaborative care, what it means. So multidisciplinary team-based approaches are more effective than solo approaches, absolutely, no doubt about it. Success is proportional to the frequency of contact. So I'm a primary care physician. I cannot see my patients who have obesity on maybe once a month at most, because I've got competing priorities and other patients who have other issues as well. So it's just not realistic. And I know that if someone can see them or someone can make contact, or perhaps I can make contact with the patient more frequently, they're more likely to succeed. Support can be provided through different means. And if you look at the collaborative care models, this includes electronically and by telephone as well. So it doesn't have to be an in-person visit, although there's some evidence that in-person visits are slightly more effective. That may be confounded by the fact that if someone's willing to come back in person, they're probably more motivated to begin with. So what does it look like? And this is probably the part I really want to emphasize to you. This is the dream that we've had. So in 2013, 2014, I believe, we started an initiative called the Adult Obesity Collaborative Referral Initiative. This was in Chicago, and the point was to encourage physicians to collaborate with weight management professionals in the community. The study that we did was sponsored by the Jenny Craig Company, which I'm not going to talk about today, but that's a commercial weight loss company, and it doesn't have to be a commercial weight loss company. But the underlying idea was for physicians and other providers to collaborate with their weight management professionals in the community to promote weight loss. And we created an online course for it and looked at some outcomes around physicians who participated. It was all physicians this time. But the collaboration may look like this eventually. And this example is in the National Academy of Medicine book as well. So you have somebody who is a dietitian who is working in the community for perhaps, who has such a good relationship with you that they ask you the question, I'm really pleased that you have helped this patient lose 20 pounds. Will you be adjusting his insulin dose? Or the dietitian has, of course, worked with them to lose 20 pounds. Are you going to be adjusting his insulin dose to reflect that? So what does this reflect? First of all, the dietitian is very aware that there needs to be an adjustment in medication. He or she has helped this patient to get to a healthier weight and has a great relationship with the physician in this case, and asking him or her to be aware of this phenomenon and to make an adjustment as necessary. This doesn't have to be a dietitian, a physician, it could be a psychologist, a dietitian, et cetera, et cetera. But essentially, this is what team-based care looks like. We are very, very far away from that. I think the participants in this ECHO series are at a great advantage because you're passionate about the issue. Many of you already work in multidisciplinary environments and have assigned different roles for the management of chronic disease to people within your environment. So we have that advantage, but in typical primary care, we're pretty far away from that. What we have are some passionate providers who are helping their patients the best way that they can, but they're not necessarily linked to community resources or other professionals in the way that this example describes. So let's take a look at this exercise. And as I said, there's no right or wrong answer, but we're going to consider some questions as we go through this. Now, some of you are in sites that have more than one person, others do not. But I just want you to think about these questions that follow this. And we're going to discuss each of them in sequence. I'll ask for a few comments, and if nobody's willing to comment, we'll see if we can call out a few folks here and there. But you are a provider in a group primary care practice just outside of Mansfield, Ohio. So I picked the geographic middle of the state, so not to sound biased in any way. So there are 4 physicians in your group, 3 family physicians and an internist, as well as 1 nurse practitioner in your practice. So there's 5 providers total. The practice has a high prevalence of obesity, greater than 50%, which is not unusual in rural Ohio. Your practice also includes a staff of 14, including 8 medical assistants and 1 full-time nurse. The surrounding community, there's hardly anything. There's a Curves, and there's some other commercial program, which isn't very reputable. There's very, very little. There's a couple of recreational facilities. Dietitians are available at the local hospital. Your task is to establish a multidisciplinary collaborative obesity care program. You've received $50,000 through multiple grants for this purpose, which I'm sure you realize doesn't go a long way. So there are some questions to address as we go through this. Whom to hire or engage, and how might you go about that? How might you divide responsibilities among people in your office and those limited resources that are available in the community? And how would you determine if you are successful or not? So we're going to stop for about 2 minutes here and give you some time to think, and then we'll go through these questions in sequence before we move on to our cases. Okay, so I hope you had some time to think about these. Let's start with the first question. So you have a small amount of money. You want to make a difference for your patients and perhaps for the surrounding community in terms of obesity. There's a local hospital that has a few professionals. There's really not much in the community in terms of resources, but there are a few things available. So who would you hire or engage to start with here? Anyone have any thoughts?
We already have a dietitian. We have a pharmacist who works with us. And I mean, I think if I was looking for, you know, some more people to add, it could be like maybe some people in exercise science that are looking at doing training or ways to incorporate that in coaching. Any ideas? Yeah, that's what we agree on.
That's really helpful. So I think you're at an advantage. You already have people who have been hired. The question is then, how do you engage them in a more practice-wide or systematic effort to influence obesity and develop protocols around it? And it sounds like you're pretty much on your way to doing that. So you'd say, hey, my job as a physician is identifying obesity, handling the comorbidities, getting people started with counseling, which we've talked a little bit about already, doing some motivational interviewing. But after that, you know, I don't want to be counseling these folks for 30, 40 minutes each time. And they may have specific dietary questions. They may have specific questions about pharmacotherapy. I've got two people here who will understand that this is what I do and that they're going to be seeing patients for this specific purpose. That's how clear it has to be. It sounds like you guys are very, very advanced in that regard. So Dr. Joyce from Concord has a comment. Hire a care coordinator, engage the local gyms for a discount for patients, utilize the hospital dietitian. So obviously using resources that are available, and the care coordinator would be helpful to coordinate some of these efforts. Engaging the dietitian doesn't mean, and we see this all the time, I see this with our residents, for example, oh, I'm just going to refer them to nutritionists because they want to go see them, they have obesity. And I've worked with dietitians for a long time, and that's not a great referral. They are very highly trained, they have lots of expertise, they like to see people with type 1 diabetes and telling them how to manage their diet with respect to insulin dosing, that kind of thing. And so sending a somewhat unmotivated person to a dietitian, probably not the best approach to it. But if you engage that dietitian in the sense and say, hey, I'm trying to make a big difference in my practice with respect to obesity. This is what I know, and this is what I do. This is my approach to it. And I'm going to refer some people to you who really want to see a dietitian and who have specific questions that you can address, or I'm asking you specific questions. That's a much more responsible and higher level referral that I think that they would appreciate. So that's one way to do it. The gyms, done a lot of this sort of thing before. A lot of the discounts are means tested. The YMCA, YWCAs often have discounts for low income families. Again, a good idea if the patient is willing to go and participate in something that is organized and helpful to them, not if they're motivated. Of course, that's an excellent idea as well. Any other thoughts before we move on about hiring and engagement as a first step? Okay, let's move on. So I've kind of already hinted at how you might divide responsibilities, but if you were to say you're a provider, and I think most of the people in this series are, and you've got this dietitian in the community, and you've got a staff, you've got 8 medical assistants and a nurse. You've got other providers, maybe they're less interested, right? There's a nurse practitioner and 3 other physicians with varying attitudes, let's say, with respect to the problem. How would you divide up responsibilities? Any thoughts about that?
I think that, you know, if you're able to have the care coordinator and they are able to do follow up with patients in terms of if you refer them to a dietitian, seeing if they are going to those appointments, or if you were able to talk with them about a discount to a gym, seeing if they're able to actually utilize that. So in between physical appointments that you would have with the provider, having that care coordinator able to do some of that sustaining work to see what they're doing in between appointments, that would be one element of kind of making sure that the care is sustaining throughout that time period in between your appointments.
Okay. And I like that. So what I would recommend, so you're saying I'm going to see this patient every month, every 2 months, whatever is feasible.
Mhm.
But in between, they're going to see the care coordinator who is going to make sure that they have connected with some of the community resources that you have already decided are useful, whether it's the gym, whether it's the dietitian, et cetera. The other thing I would recommend is that you write all of that down and make sure that everyone in the practice understands that. This is what I do. I'm going to handle their diabetes, their high blood pressure, their lipids, their sleep apnea. Of course, I'm going to do all that. And I also am going to provide some counseling and I'm going to do some motivational interviewing and see if they're meeting some basic goals. But that's the extent of my limitations here. I don't know how they're doing with the gym or if they've got their medication, et cetera. There's somebody else who's going to take charge of that. I don't know if they've seen a dietitian who has recommended a calorie goal or whatever it happens to be. But there's someone else who takes care of that as well. And we're going to write this down and I'm going to send it to the hospital dietitian and I'm going to send it to my care coordinator and the patient as well, so they know who does what. And from time to time, hopefully you're all documenting in some unified fashion. You can see what people are doing. So that's kind of the dream arrangement. That's what we're aiming for. It doesn't happen overnight, of course, but what you described is exactly correct. There's a comment here from Crossroads. Use peer support and education in substance abuse. Has that been used in weight management? So yes, of course, it's been used in substance abuse, including alcohol and narcotics very, very often. And yes, it has been used in weight management. Now, with some caveats, how do you define peer support? So in the adolescent literature, we know, I didn't do this study, but it was before I got involved in behavioral economic approaches to weight loss, which I don't necessarily recommend, but so you would pair, there are investigators who pair two adolescents together, and they're usually very similar. So if it's two 15-year-old girls or two 15-year-old boys, it tends to work better. And they often have similar interests and similar challenges. It's video games or it's sugar sweetened beverages, et cetera. And you say, look, you have a goal, and I don't like assigning weight loss goals to children, but you have a goal collectively to lose 30 pounds between the two of you. It tends to work really well. They both tend to do well, because if someone has only lost 5 and the other person has lost 15, boy, do they get some pressure to step up a little bit and to be engaged in it. So there's that sort of peer support and peer effort, but that's very, very intense. On the other hand, there's been lots of literature around peer support for weight loss. And actually, we're starting a group to do exactly that for our patients in January. Part of it is practical because we can't see patients often enough and we can't see everyone. And if we have too many follow-up appointments, we can't see new patients. And part of it is this is another mechanism of providing support that might be helpful. So we are going to select peer leaders who have had a lot of success in achieving a healthier weight to kind of lead these peer support groups. So that does help as well. Again, it does fit into this collaborative model. So now you've got patients engaged as well. So you've got the provider, you've got a nutritionist, you've got, in the case of the first center, Crossroads, Total Health, you've got a pharmacist engaged. You probably maybe have a behavioralist engaged. Now you've got your peer group leaders engaged as well. Perhaps they can meet in your facility on certain nights and discuss their challenges in achieving a healthier weight. Now, there are lots of caveats. Sometimes people don't show up. Sometimes it's the same people coming all the time and they're doing well. But nevertheless, it's a service that's available. Shweta has a comment. Time allotted to see patients with obesity. Have MA interview, then come patient nurse with visits for weight as well and detection if possible the same day. Can hire and engage them. Okay, so I think Dr. Walker is talking about assigning responsibilities in various ways, and this certainly makes sense. Again, analogy from the pediatric world, we have something called the Big Five calculator. There's 5 or 6 habits that contribute disproportionately to obesity. The parent completes this on behalf of the child in the waiting area. The assessment is then just viewed very quickly by a medical assistant who says, oh, well, here's your score. These are things you need to work on. And she sticks it on the door where the provider is going to see the patient. The provider then has this and they can say, well, wait a second, you're obviously not getting enough physical activity. Let's talk about that. So there's a focus. So at 3 different levels, the same message is reinforced. And that's similar to what Shrika is suggesting, of course. So the MA gathers some information, they get some counseling from a nurse, they get some counseling from the provider, and it goes full circle over and over again. The more people who tell you to quit smoking, I think is the more likely you are to succeed. It starts with your spouse, your kids, your employer, your classmates, your physician, your or other provider, your nurse, your medical assistant, your dietitian, your coach, everybody, your personal trainer. If they keep telling you the same thing, hey, I think you're going to get the message eventually. And that's the approach that we use within an office as well. Okay, let's move on to our last question. Metrics for success. Let's say you've established this program, you have some financial resources to do so. And when I say metrics for success, the obvious one is how many people are achieving a healthy weight and go from obese to a healthy weight, which is a really, really ambitious metric for success, given that this is a chronic relapsing condition that people cope with throughout their lives. So let's leave that one off the table. How else would you know if the collaboration is successful, either anecdotally or through some sort of quantitative measurement? Super obesity is different than normal obesity. The center I was working at in Pittsburgh a number of years ago was a site for something called the Teen Lab Study, the Teen Laparoscopic Bariatric Surgery program, which is actually a study based in Cincinnati. Cincinnati has an outstanding adolescent obesity program. And in those days, this was in the early to mid 2000s, to qualify for bariatric surgery as an adolescent, the criteria were very, very restrictive. You had to have a BMI of 40 with no comorbidities, or a BMI of 50 40 with comorbidities, 50 without comorbidities. Now, a lot of adolescents, no matter how obese they are, they don't have comorbidities because they're so young, right? So we were actually looking for adolescents who had a BMI of 50 or higher. In our Epic electronic health record, which is hundreds of thousands of patients across Western Pennsylvania, we found 3 such adolescents. There were tons of kids between BMIs of 30 and 40, just as there are tons of adults. So there are tons of adults with obesity weigh between 200 and 300 pounds. There are very few who are 500, 600, 700 pounds. There have never been very many of them. And the number of those people hasn't really increased. If you go back to the 1970s, there were a few of these people, and they made the news. Oh, this lady needs to be transported out by the fire brigade, and she can't get out of her house. Those people have not really increased in numbers significantly. So this is a different phenomenon. The only person I think that I know of who studies these folks in detail is somebody named Sonia Caprio, who's at Yale. And her average patient has a BMI of 80, believe it or not. And she will tell you, I went to a couple of her lectures once, they are fundamentally different than everybody else. So everything we've talked about has been largely addressed to those people who are, we've talked about cultural differences, we've talked about collaborative care, we've talked about pharmacotherapy, we've talked about all these things. Those apply mostly to people who are class 1 to class 3 obesity, BMIs of 30 to about 45. Beyond that, we're talking about a unique and very small population. Adam, did you have any comments?
One thing to keep in mind with patients in the most sort of often dire circumstances. Certainly, I've not encountered a patient like this, but in other dire circumstances, is that on the care team, sometimes we experience compassion fatigue when we have patients in really dire circumstances like this. No matter how friendly and good they are, we actually ourselves can experience some wounds and some frustration and, leading to downstream consequences, and just really being sure to, keep those things in mind for yourself and the rest of your care team when caring for a patient like this, because I think frustration can brew fast. And always going back to that concept of patient-centeredness that it sounds like you've been starting with.
Thank you, Adam. And I just want to echo something that Adam was. I think that Gina should be congratulated for investing in this patient. This is a very, very small number of people, first of all, and I'm guessing he doesn't get treated all that well by a lot of folks, doesn't see a lot of folks. So I'm sure he appreciates the attention and the care that Gina provides for him. And that itself is therapeutic to some extent. She cares about him. She wants him to get to a healthier weight. He may not be that interested, but without her, I think things would probably be worse. So, Jim, any comments?
Yeah, and I want to commend you as well for the great job you've done working with this patient, and your patience and your fortitude in continuing to do everything you can to help the patient. His environment, his home environment, and just kind of following up to what Gautam was saying, is so key to where he's at. And so he's with his brothers, they're all on disability, and someone is shopping for him and providing this food source. So really, ideally what we would love to have, I think, is a household intervention for all three of them, since they all three have weight problems. And to the brothers may be more, easily engaged around weight loss. It would be worth exploring that. And because they are all on disability, there's also the risk of a real learned helplessness, kind of an environment where they feel like everything they do is futile. And so if you could have, ideally, again, in some way, I don't know if it could be through disability, through your clinic, a behaviorist, someone who could engage the three of them together or three of them individually around weight loss and the food environment that they have at home, and what they want for their lives, what their values are, and really where they're at and how they can improve their health, as well as the health of the patient, the key patient there in this scenario. So I think I think it will be difficult to work only with the patient and not the brothers, because they're really a family unit and working together. The other thing, your patient, I think it's a real possibility the patient could have a personality disorder. I don't know if a psychiatric referral could be helpful. Personality disorders, if he does have one, they're notoriously difficult to treat, but progress can be made. We don't really know. We don't really know what's going on with him, but seeing a psychiatrist, at least a consult with a psychiatrist or a social worker or a counselor, whoever you may have access to, who can do some assessment of that to see what's going on with the patient, could be helpful. So really, it's, my thoughts are, it's the household environment that is really helping to continue and this problem that the patient has, and working from that perspective, and also potentially from the psychiatric perspective. And then medications may be really in order for this patient, weight loss medications, although the patient has a very long way to go, it may help blunt his appetite somewhat.
Okay, thank you, Jim. We need to move on. Shannon, back to you for a moment.
Yep. Everybody should have received a feedback survey. This is just an additional survey. We're trying to get some feedback about the whole series in terms of what we might be missing or what things were left unsaid. So if you could please fill that out before tomorrow at 5 p.m. That will inform our next clinic, which is next Thursday. It's our last week. And at that time, you will receive 2 surveys, actually 3. You'll get a post-clinic survey, an exit survey from us, and then you'll get an myevaluations.com survey. That is for anyone who wishes to claim CME credits. So be aware of all those coming out. We are still, next slide. We are still recruiting for our hypertension series. A couple of you have re-upped. Thank you so much. And if you would share this with your colleagues, we're talking about reducing the burden of hypertension in the spring. Next slide. I think that might be it. Oh, you can always view our clinics online if you register on our website. And I think we will see you guys next week. Have a great week. Thanks for sticking around for a couple of extra minutes.
Thanks,
Bye.
everyone. Bye-bye.
See, I already saved my
Just
chat.
save it.